you. Would you prefer if I use this or just speak? Right. Okay, thanks. Good morning, and thank you very much for having us here today. I think it's fantastic you've come together as a group to try and sort out Lynch and educate people. So thank you very much for having us here. And as said, Athalie, Melville and Demetra, Georgiou and I, we are from the North West Thames Regional Genetics Service, and so we're based in Harrow, and we are a few floors above St Mark's. So we work very closely with colleagues from St Mark's, which is a specialist bowel centre which moved from central London out to Northwick Park a number of years ago. And actually Demetra works jointly between us and St Mark's. So you've probably heard of that hospital. And what I'd like to say is this day is really for you, and hopefully what we're going to say is going to be of help and answer some queries. Some of you may have heard what I'm going to say all before and understand it, but others may not have. But basically it's for you, so we're going to be around, so please do ask us things, and so hopefully we'll be able to give you some answers, or if not, we'll go away and we can come back to you. So my role is to sort of give an overview of Lynch syndrome, and this slide just is really showing the main points I'm going to cover. So what it is, briefly about the history, how common it is, how it's inherited, and the main clinical features, and the genes that have been identified to date, and what the risks are, and the current screening and the studies that we suggest to families where we find Lynch syndrome. So Lynch is an inherited alteration in DNA mismatch repair. So when our cells need to divide, the DNA needs to be copied. When we copy our DNA, we always make mistakes, and it's really important that those mistakes are corrected. So it's a bit like the genes for Lynch correct those spelling mistakes. So if the genes aren't working properly, the spelling mistakes remain. It's a bit like spell check on your computer. If the spelling's all out of sense, you can't read the genetic code properly, and then the cell growth is affected. So when there's a mismatch repair gene defect, or defect within that pathway, it increases our risk of certain cancers, and in particular bowel cancer, and also other cancers. And when there's something and something else, so two things running together, we use the term syndrome. So that's why the word syndrome is used. And the condition's dominant, which means if somebody's affected, they have a 50-50 chance of passing it on to their children. In Lynch, the tumours occur generally when people are quite young. They do occur older as well, but often young. And when a cancer occurs young in a family, we think it's more likely to be genetic. And in Lynch, the tumour development process is faster than, say, in the general population. So if someone in the general population has a bowel polyp, then often the change from it just being a benign polyp to cancerous takes a long time. It can take between sort of 10, 15 years. Whereas what's recognised in Lynch is it's a faster process, which is why the screening needs to be done more frequently in Lynch. So we screen individuals younger and more frequently, so up to within 2 years, rather than general population. In some families we would suggest 5-yearly screening. And the characteristics of the tumours in Lynch, they have these features of microsatellite instability and loss of the mismatch repair genes, which I'm going to come on to, but Dr Brady is going to cover that in much more detail. So briefly the history. So the family G was reported in 1913, and in 1966 Dr Lynch and colleagues reported 2 large families, and they looked again at the original family G reported. And the term Lynch syndrome was coined in 1984, and when I started in doing clinical genetics in the 90s, we used to use Lynch 1 when it was predominantly a bowel cancer family, and Lynch 2 when there was other things in the family, so other cancers like endometrial cancer, ovarian cancer, skin cancer. And then as the genes became identified, we used the term hereditary non-polyposis colon cancer, so a lot of the literature has got HNPCC, and basically that was to distinguish it from other hereditary types of bowel cancer, and in particular, some of you may have heard of a condition called FAP, familial adenomatous polyposis. I know that Dr. Monaghan's going to show slides of this later just to help you realise the differences, but in FAP you get thousands of polyps often throughout the bowel, so it's like a whole florid bowel covering loads of polyps, which is different in Lynch. Lynch you just tend to get a few polyps, and so we use the term HNPCC, but actually now what we use is Lynch syndrome. And in the 90s, this is when the gene started to be discovered. So Lynch is one of the most common hereditary forms of bowel cancer. So in 2010, the figures were, incidence was 1 in 14 for males in the UK and 1 in 19 risk for females in the UK of developing bowel cancer. And of all the bowel cancers, Lynch accounts for about 2 to 3%. So as you can see there, the majority of bowel cancer is sporadic, so about 60%. And then in certain families we see more bowel cancer, but it's not usually just due to a single gene. And then these genes here are pointing to the sort of high-risk single genes, such as the FAP I mentioned, where you get thousands of polyps, and Lynch probably accounts for about 2 to 3%. I know Ian's going to go more into the overall risks. So as I said, it's dominant. So if you take a blood and you look down the microscope, people in our labs look down the microscope, and you see all these strands, and these are our chromosomes, and packed onto these are all the genes. And so usually in the cell you've got 46 chromosomes. Females got 1 to 22 pairs, numbered 1 to 22 and 2 X's. And a male's got, again, 46 chromosomes, got 1 to 22 pairs of an X and a Y. And when a man makes his sperm, he puts one of each of these into the sperm. So if the sperm gets the X, it's going to be a girl, and the sperm gets the Y, it'll be a boy. And so basically, the genes are dominant. So if you have a faulty gene and a normal copy of the gene, so you inherit the faulty gene, and then at some point something happens to the good copy of the gene. Thank you very much. And that's when the cell starts to be abnormal and to grow abnormally. So this is just showing a pedigree where you've got an affected father, and he's got one normal gene, a faulty gene, and partner, and then there's a 50-50 chance of passing on the faulty gene. Obviously you can get the gene and not necessarily show the cancer. So not everybody that gets the gene shows the cancer, but obviously if you do inherit the gene, you've got a much higher chance. If you don't inherit the gene, then you're not at risk of passing it on. So again, so like the MSH2 gene, which is one of the main genes for Lynch on chromosome 2, if you've got the faulty gene, it's a 50-50 chance of you passing that on. Thank you very much. Lots of water. So this is showing a pedigree. So you've probably seen pictures like this, or seen this, where a circle represents a female and a square is a male. And if somebody's affected with something, then we usually colour them in. So in this family, this great-grandmother's been affected with endometrial cancer, which is cancer of the lining of the womb. She's got the gene, there's a 50-50 chance to her offspring. This is showing bowel, this is showing somebody who's had polyps and therefore likely affected or inherited the gene, and then their children's risk is 50-50 of passing that on. And the daughter's developed endometrial. So how do we sort of make the diagnosis? So in families, if there's a lot of cancer at an early age, or certain patterns of cancer, such as bowel cancer, plus maybe a lady in the family's had endometrial cancer or ovarian cancer, that makes us think about it. In the labs, Ian's going to talk more about this, but when the pathology specimen comes into the lab, they're alert to certain cancers, and could this be Lynch related? So they may do certain tests on the tissues that come in, and if they show abnormal results of immunohistochemistry or microsatellite instability results, that suggests that could be Lynch. And then that pathology report would say, think about Lynch, and then refer to clinical genetics. So, and then if there is evidence of mismatch repair immunohistochemistry problems, that's when we can get a clue from that to look at the genes for Lynch. So these are the genes that have been identified for Lynch syndrome. So MLH1 and MSH2 account for the majority of cases. You've probably heard of these specific gene names, and there's also faults in these other genes that have been found, and all these genes are involved in the pathway. So once one was found, they looked at the pathway and managed to identify other genes in the pathway. So to try and sort of recognise families, I just want to mention these terms, but basically this Amsterdam criteria was developed. You've probably heard of that. So the original Amsterdam criteria, basically we think of it as 3-2-1. So 3 people affected, 1 at least as a first degree relative of the other, so like a mother or brother or sister. 2, meaning 2 generations, so it's going from parent to child or grandparent to parent. And 1 is somebody at least under 50 is affected. So 3-2-1 rule for Amsterdam. So Amsterdam type 1 was regarding bowel. Then they changed it in '99 to include other cancers, so not just bowel, other cancers. Then there's been the working criteria, which has helped the labs in terms of when samples, bowel tumours, other tumours come into the labs, when do we do this testing to look for evidence of Lynch? So this is just showing what we mean by microsatellite instability. So the genes for Lynch are important for repairing the DNA. So if we suspect Lynch, what we would try and do is actually to get a sample of the bowel tumour. And these microsatellites, within our genome, we've got lots of bits which we don't actually need, but we've got these areas of repeats. They're called CA repeats. And so these are inherited in a sort of length between generations in a family. If the mismatch repair is not working properly, then you see variation in the length of these repeats in the affected tissue, so in the tumour. So this is showing from the blood sample, you see this repeat, and then when you take the tumour from the sample of the bowel tumour, so we go to the pathology lab, so we get the tumour, and then we do the studies on the actual tumour, and we see this slippage. So you're seeing 2 peaks instead of the 1 peak. So actually, you think, how are you doing this? So the lab actually get the tumour, and they take out the cancer bit, and they do the satellite testing on that, and then they take out the DNA from the adjacent normal-looking tissue, and they can see this slippage, this variation in CA repeat, and that suggests microsatellite instability, which is a strong indicator that the mismatch repair genes aren't working, and that it could be Lynch. The other thing the labs do is something called immunohistochemistry, which is like a stain. A stain, when the gene works, it makes a protein. So if you stick a stain on for the protein, you expect to see it if the gene is working. But if the gene's not working, when you use the stain, it doesn't stick on. So this is showing normal staining for the genes, and this is where the stain's not sticking on, suggesting that that particular gene isn't working. So we use this to get a clue as to which gene to look at in the germline DNA, in the DNA taken from blood. So just to summarise, so we suspect from the family history, then we do the so if we see a family where it fulfills Amsterdam, then we'd say, actually, can we get a sample from your affected brother or father, try and do the studies, immunohistochemistry, microsatellite instability, and then go from there to look at the gene. So what cancers can Lynch syndrome cause? So the main cancer, and certainly from the original families, was bowel cancer. And in females, there's a risk of endometrial cancer, high risk of endometrial cancer, and Dr Angela will talk more about that. But essentially, the endometrium is the lining of the womb, and also ovarian cancer. So this is just showing here the uterus, and then there's the fallopian tubes and the ovaries here. and this is just showing the bowel. And also, just in Lynch, often the colorectal cancer is in Lynch compared to general population, there's a higher chance of what we call right-sided, so this side, so in the ascending colon. So the other cancer, there is a slightly increased risk of the other cancers, but it's quite low, and we don't generally do screening for the other cancers listed here. But this is in one of the, so originally and currently in our information leaflet, we say the risk for bowel cancer is up to 70% for men and 45% for women over a lifetime. But actually some of the more recent studies have shown that actually the risk is lower. And if we're screening people, then hopefully the risk is going to be really low. If we identify Lynch, we screen people, we will prevent the cancers from happening. And the cancer of the womb is up to about 40%, and of the ovary about 10%. I just wanted to mention Muir-Torre syndrome, which is a variant of Lynch, and the genes for Lynch can all be associated with Muir-Torre, but more likely in MSH2, but not just MSH2. And in particular, some individuals have an increased risk of getting lesions of the skin and the sebaceous glands, which make an oily fluid. So this is called a sebaceous adenoma. And some individuals get sebaceous carcinomas, which often occur around the eyes, and keratoacanthomas, which are changes which occur at within the hair follicle, at the tip of the hair follicle, and lesions like this, which actually can disappear quite quickly. They can grow over a few weeks and then they can disappear quite fast. So they don't necessarily all need to be resected or to have treatment. The other thing is some individuals, they have increased risk of sort of aging of the skin and of developing squamous cell carcinomas. So that's just a variant to be aware of. And in families where we suspect Muir-Torre, then it's important to get regular follow-up under the skin doctors, the dermatologists. So Athalie and Demetra are going to go more into the sort of genetic testing and things. But essentially, if we suspect Lynch, then we try and identify the gene within the family. Sometimes we see families because the gene's been found, and then we can offer testing to at-risk people. And it's important we talk to them to make sure that they want to know if they've got the gene or not. I think where we are at the minute, if we suspect Lynch, we do the immunohistochemistry and the microsatellite instability, and then go from there to do the genetic test. What's being developed in genetics are these panels where we can actually look at a large number of genes in one go, and maybe in the future that's the way the testing may go, but we're not doing that at present. So just wanted to mention that for certain genes there's certain increased risk of certain things compared to others, but so this slide just shows some of the variation. So in MSH2 the risk of other cancers other than bowel can be a bit higher, and in PMS2 all the tumours tend to be less frequent. In MSH6 then things often come at a later age. So finally, just want to mention about things that we do to try and help individuals with Lynch, and essentially it's screening and risk-reducing surgery. If there are any symptoms, hopefully people can contact their doctors who are looking after them, or their genetics, and we can help. Sometimes we've got a bit more time than other doctors to try and look into symptoms a bit more quickly, or refer to relevant people, and also chemo prevention. So this is my last slide, and this is just summarising the current recommendations, and other colleagues today are going to talk in much more detail about the various screening and things. But essentially colonoscopy in individuals at risk needs to be done from 25. In some families we suggest it from age 20, and it should be carried out at least every 2 years. For females, there's screening trials for endometrial cancer. There's no proven screening for ovarian cancer, and really the recommendation is risk-reducing hysterectomy, which is removal of the womb and the bilateral salpingo-oophorectomy, so removing the womb and the fallopian tubes and the ovaries. And that's usually recommended about the age of 40, so the cancer risk doesn't really go up for endometrial and ovarian until sort of over the age of 35, so around the age of 40, ideally. Professor Byrne's going to talk more about chemoprevention, so it's recognised aspirin can reduce the risk of developing bowel cancer, and there's the launch of CAP3 study, which is taking off, and hopefully this will give more hope for treatment and reducing the risks. The risk of prostate cancer is slightly increased in Lynch, probably 2.5 times general population risk. The risk in the general population is about 1 in 14, about 8%. So for certain individuals with Lynch, men over age of 40 are being invited to take part in the IMPACT study, which is a targeted prostate cancer screening study. And I'm not sure if anyone's been involved in that here. I can tell you more about that if you wish. Sometimes individuals have gastric symptoms. In that situation, we recommend that they consult the GP and have Helicobacter pylori excluded. So it can be done by a blood test, a breath test, and given antibiotics. But if there's a family history of gastric cancer, stomach cancer, then for those individuals, some rarely, but because it's not proven, some families will recommend gastric screening for gastric cancer with upper GI endoscopy, as well as obviously bowel screening and colonoscopy. And essentially, if there are symptoms, they need to be investigated promptly in Lynch. And if somebody does develop cancer, then generally the surgery is more extensive compared to somebody who doesn't have a strong family history. But Dr. Monaghan will talk more about that treatment. So, thank you. Should we carry on with, does anybody want to ask any questions urgently, or would you like to carry on and then answer any questions? Should we carry on?
Yeah.
Okay.